Welcome all to Concurrent 2, Patient and Provider Experiences. My name is Mena Bhavsar with Canada Health Infoway, one of the co-hosts of eHealth 2022. This session includes two 15-minute oral presentations. If you have any questions or comments for our speakers, please type them directly into the Zoom chat and we will address them as time allows. You are also encouraged to connect with speakers after the session via the virtual event platform. I'd now like to welcome to the virtual stage our first presenter, Christine Harris, Innovation Manager with Canadian Cancer Society.
Thank you, Mena. Hello, everyone. My name is Christine Harris. I am the Innovation Manager at the Center for Cancer Prevention and Support at the Canadian Cancer Society, and I'm pleased to be talking about work we are undertaking to support young adults in navigating their cancer experiences. First, I'd like to take a moment to acknowledge everyone who has made this work possible. Thank you to the Canadian Partnership Against Cancer who funded this project. I'd like to recognize the Canadian Cancer Society project team, our research partner, the University Health Network, Princess Margaret Cancer Center, Adolescent and Young Adult Program, our design partner, Healthcare Human Factors, our advisory committee of AYA experts, and our young adult collaborators with lived experience of cancer. So I'll start with some background surrounding our challenge. Young adults with lived experience of cancer are a growing population in Canada with a high degree of unique and unmet needs. They live in the gap between pediatric and older adult services and therefore experience challenges accessing relevant supportive care as they navigate their cancer journey. Our project challenge is how might we help young adults living with or beyond cancer access information and support services relevant to their unique needs. We focus on oncofertility, which addresses fertility challenges due to cancer and its treatment, as it has been identified as a major unmet need for this population. However, our approach also encompasses multiple challenges faced by this population. Our objectives of this project were to engage young adults in research and co-design to better understand their needs, to prototype an intervention to address their unmet needs, and to develop an implementation plan for the proposed intervention. Okay, so our approach for this work has been human-centered, and we've been guided by the needs and desires of young people with cancer, involving them in our research and co-design. In the research phase, we conducted secondary and primary research, including a literature review to capture the challenges young adults face, and a program and service audit of national cancer supports, which serve young adults. We follow this up with a national survey about their experiences, health, and support issues. And next, we held focus groups, which were national in scope, where participants discussed their experiences, challenges, and potential solutions. And we moved into design with our co-design workshops with young adults in our early design process. And these informed our decision on the type of intervention we decided to design. And next we began prototype design with a first version. We conducted usability testing of the prototype with young adults. And then we took the feedback from those sessions and designed the second version of the prototype. As part of our knowledge translation efforts, we developed and are sharing knowledge artifacts to inform future design and development of this intervention, as well as to inform other work related to supporting young adults with cancer. Okay, so our research revealed three overarching themes which inform the design of our intervention. Young adults living with and beyond cancer have a unique and changing context. So their cancer experiences are unique to their population, and their circumstances and needs change very rapidly given their life stage. Some of the things we heard were, I couldn't find information related to my age or situation, or my provider asked me about my life situation, and then it changed, and then they never asked again. The second theme was the need for tailored and timely information and supports. Supportive care should be specific to the unique needs of this population and delivered when it's needed. We heard in focus groups, folks say, I wish I knew what to expect, or I was overwhelmed with information at diagnosis, but didn't get support at other times. Or it would be nice to feel a bit more in control over the information I'm receiving, and I'd like a place to get the right information. The third theme is a desire to connect with community. This group wishes to learn from and support others with similar backgrounds and experiences. We heard, I wish I could learn from the experience of someone like me. So in summary, our research revealed that young adults are often unable to navigate health systems to access relevant and timely information and supports, resulting in feelings of unpreparedness and lack of support throughout their cancer experience. Okay. We use the insights from our research to develop a list of must-have requirements for our intervention, and this list was validated by the folks we co-designed with. It included provide supports that are specific to young adult experiences, support ever-shifting needs, help prepare young adults for their experiences, provide timely support, give young adults control over the information they consume, provide trusted and credible information, and allow them to support and connect one another. I did see that there was a question asking about the age range, and we were working with young adults from 19 to 39, consistent with CPAC's definition, which is 15 to 39, but we focused on those who are 19, just given some of the challenges that we had with parental consent for those under the age of majority. So I'd like to highlight one activity from our co-design workshops. In these sessions, the voices of young adults were prioritized and team members were only present as either observers or facilitators. We ran a journey map activity to better understand the cancer-related experiences of participants from diagnosis through to post-treatment. And we used persona profiles that were informed by our research. Participants use these personas to share insights from both the persona's point of view and their own perspectives about their cancer experiences, needs, and interventions to address them. Pictured is a screen of the 2 journey maps of our personas. This allowed us to determine and envision our intervention, which I will reveal right now. So we are currently calling our intervention Candle. It's a working name. It is a digital web app available on any device that will help young adults navigate the uncertainty of their experience with and beyond cancer. On this and following slides, you will see screen images from our mid-fidelity prototype. And the first feature is a profile. During onboarding, the app will ask the young adult user to answer questions about their cancer type, where they are in their experience, their life circumstances, and support interests. And the information will allow the app to create a curated experience for the user. The user may update their profile at any time. So the user's curated content will appear on the dashboard. This is their homepage and the primary touch point with the tool. The content on the dashboard is delivered just in time and is based on their profile inputs. The dashboard also uses occasional prompts to remind the user to update aspects of their profile and check in about their needs at any given time. Next is the library, which is the tool's main information hub and includes general information, articles, resources, and checklists. The dashboard will pull relevant content from the library, and the user can also explore the full library at their own pace. It will integrate content from the Canadian Cancer Society and other cancer organizations nationwide. What you see is displayed is the resource section, which will pull relevant resources for the user based on their location and profile interests. We also heard from young adults that they would like a checklist of resources that they can use at specific points in their cancer experience. And these checklists will outline things they should be aware of or consider as they navigate their experience. We intend to co-design these resources with young people impacted by cancer. The last feature is the Candle community. This section will allow users to share video, audio, image, and text posts about their cancer-related experiences and consume the posts of others in a moderated environment. We are very proud of the prototype for this digital tool for young adults to access information and support, and we look forward to continuing the work to develop this web app alongside our partners and stakeholders. I'd like to close with some words from Rhea, one of our collaborators who had cancer as a young adult, and we keep this at the forefront of our thoughts because it motivates us to keep going. It has really been an amazing experience to work with your team. You have been so thoughtful and so personally dedicated to this project. The prototype is really a reflection of the team's incredible skill, and I'm sure once the product is launched that it will be so useful. I can tell you that I would have absolutely loved the Candle app had there been something like this when I was first diagnosed. Okay, so thank you. And I'd like to open this up for questions. Mena, I don't know if anything has come up.
Thank you, Christine, for sharing your story on supporting young adults accessing cancer care. We do have one question here. What languages are available at this time?
Right. So again, the prototype is still being developed, but as the Canadian Cancer Society is a bilingual organization, we foresee at this point that it will be available in English and in French. But that does not mean we will not be having other conversations to see what we can do from a language perspective to make sure that we are being inclusive for young adults from different backgrounds.
Thank you. Is it the intent that the Candle app prevent direct messaging?
So that's a very good question. So right now, again, we're in the early stages of prototyping, and we're taking a little bit of a walk, crawl, run perspective. Ideally, we would like to have a thriving and active community right now, but we are going in stages. And so right now, folks can identify in their profile if they would like to connect with other folks and do so outside of the app. The intention is eventually that they can be able to do that in the app. And those are all details we haven't quite yet worked out. We don't want to make those decisions without collaborating with AYA experts, without young adults themselves. And so again, there's so much more work that needs to be done. And the intention is to, yes, have a thriving community where folks can connect with each other.
Did you say there was a similar app for older adults?
I didn't say that. We have done some research, I should say in Canada, but we've also done a little bit internationally to identify existing apps. And so I haven't necessarily seen one. That doesn't mean that doesn't exist. And if you have seen something that can give us ideas on what we could do, please do share it with me. My contact information is on the screen.
Does the prototype collect user information, or is it fully anonymous access?
It's a good question. So yes, the intention is for the prototype during onboarding to collect user information. We heard from young adults because we were trying to figure out how comfortable would they be, how not comfortable would they be. They said they would be comfortable with providing it so long as it was very clearly established how we'd be using it and that we had high privacy regulations that we were using. So they said they were comfortable with that because they would know that it is tailoring the experience to that. However, for those who are not comfortable with sharing personal information, there is the opportunity to skip onboarding and just kind of freely check out all of the resources that are available on app. We wanted to make sure that we were serving a multitude of needs and wants. And so we wanted to make sure that we were providing for those who want to provide their personal information and those who don't.
So we have about 40 seconds, and I do have a question here. ETA on production release of app, is this expected to be free for clients, and are developers of the app all internal to Cancer Agency or utilizing eHealth staff?
Wow. A lot of amazing questions. It's really difficult for me to answer them right now. We are in the process right now. We've been finding funding because we want this to be sustainable work, to continue to do this work, and we are planning for those next steps. This needs to integrate with other things that are happening at the Canadian Cancer Society, including our digital transformation and integration with other content that is available. But we also need to have conversations to decide what is the governance model for this tool. It might be Canadian Cancer Society, it might be in partnership with other organizations. And so it's really important for us to make sure that we have the right people at the table to make the decisions about how best to create this app for the community and what is best for them. So we don't quite know yet.
Thank you. Unfortunately, that's all the time we have for questions for Christine. So thank you again for sharing your story. Up next, I'd like to welcome Neesha Hussain-Shamsy, PhD candidate of the University of Toronto.
Hi, everyone. Thank you so much, Christine, for your really interesting work on supporting young adults with cancer. As Mena mentioned, my name is Neesha Hussain-Shamsy. I'm a PhD candidate at the University of Toronto's Institute for Health Policy, Management and Evaluation. And I'd like to thank you for joining me today for this presentation on our work to describe provider experience facilitating ambulatory hospital-based synchronized video group health interventions. So group-based health interventions like group therapy, education, and exercise are a really important component of health promotion and management for a wide range of health concerns. Areas where group programs have been shown to be effective include mental health, cardiology, endocrinology, for example, in diabetes management, and more. In-person groups were a key feature of health programming delivered at Women's College Hospital, referred to as WCH, a tertiary ambulatory care hospital located in Toronto, Ontario. Of course, access to in-person programming, as we all know, was severely disrupted as a result of the pandemic. In order to ensure continuity of care, given the unknown duration of closures to in-person activities, and in alignment with the long-term strategic plans at WCH, our institution developed capacity to deliver synchronous video-based group programs by integrating Zoom with the hospital electronic medical record and patient portal delivered through Epic. This allowed for secure access, clinical documentation, and long-term sustainability beyond the pandemic. Literature on video groups has by and large been limited to patient perspectives and pilot studies, as there were few examples of institutionally driven sustainable efforts to shift to video groups. Information on provider or facilitator perspectives on the implementation and facilitation of these video groups has been missing. Therefore, the objective of our study and this presentation is to describe to you at a high level the provider perspectives and experiences of the implementation and of facilitating video groups at Women's College Hospital. To do this, we administered a brief cross-sectional survey to all video group facilitators at Women's College between September and November 2021, which was just about 18 months after the video group implementation began. In addition to questions related to demographic and professional background and a measure of electronic health literacy called eHeals, we also asked questions conceptually related to implementation, informed by the work of Proctor et al., and related to the experience of providing care informed by the quadruple aim. Measures of implementation that we considered and could measure in this specific study included acceptability, appropriateness, fidelity, cost, and feasibility. We analyzed the data descriptively. To give you a little bit of more context for these results, in the first 6 months of the implementation, so going back to 2020, 29 video groups were run across 5 hospital divisions. This involved 48 facilitators and 767 unique patients. And this was quite consistent during the time that this survey was running as well. Our facilitator survey had an 83% response rate with a sample size of 40 facilitators. Most respondents were women between 40 and 49 years old. Professionally, most had been in practice for more than 10 years and represented a variety of occupations, including physicians, social workers, and mental health and physical health therapists and professionals. The vast majority had facilitated more than 6 video groups, and all divisions at the hospital with ongoing video groups were represented. With respect to our sample's technological proficiency, most rated their comfort with day-to-day technology as very good or excellent, and none rated their comfort as poor or fair. The mean eHeal score of electronic health literacy, which was 33.7 out of 40, which compared to the literature is quite high. For about 3/4 of respondents, the last video group they facilitated was therapy and orientation, the remaining being education or exercise focused. According to, facilitators noted that the technology was easy to use, that they felt comfortable using it, and gave their overall experience with the technology itself a mean score of 8.3 out of 10, suggesting that the way that Zoom had been integrated with Epic was quite acceptable to them. They were also reasonably satisfied with the care they provided virtually and felt that video groups were sufficient for helping them address patient needs, giving it an average score of 3.8 out of 5. Facilitators were a bit more neutral about whether the quality of care they provided virtually was similar to that of in-person groups, giving it an average score of 3.5 out of 5, and quite ambivalent about whether their costs in terms of time and effort were any different. With respect to the feasibility of the implementation, most facilitators experienced technical and practical barriers at 52% and 67% respectively that made it difficult to facilitate a group. Very few facilitators experienced anything that made them worry for their own privacy, confidentiality, or safety, but 2 in 3 did experience something that made them worry for that of the patients participating. Thinking about the actual experience of facilitating a video group, facilitators gave their experience as a video group facilitator a very high ranking of 8.5 out of 10, and noted that they would be very happy to facilitate a video group again with an average score of 4.4 out of 5. In line with this, they gave the experience of facilitating a video group a mean net promoter score of 8.5 out of 10 based on the question, how likely are you to recommend facilitating a virtual group to a colleague or peer? Looking forward, most facilitators noted that they would be happy to facilitate a virtual group again, 4.6 out of 5, but were more ambivalent about choosing to facilitate a virtual group versus an in-person group if given the choice, 3.3 out of 5. Qualitative feedback based on free text responses to the survey included the following. The noted technical and practical challenges included things like internet connectivity, particularly on the patient side, patients that had trouble logging in and would join the video group late because of their own lack of technical ability, which could be disruptive to groups, and trouble finding appropriate private spaces to conduct groups, both from the perspective of patients needing reminders not to have others in the room due to privacy considerations, and facilitators having trouble finding appropriate private spaces in their own homes, particularly in the early days of the pandemic, and at the hospital as clinical services resumed, creating demand for private offices and clinical rooms that had the appropriate technical equipment. Benefits highlighted included better access for patients, the ability to treat more patients, and improved attendance. Drawbacks included trouble with group cohesion, the lack of nonverbal cues to inform facilitator responses to patients, Zoom fatigue, as many of us might be familiar with, and the steep learning curve at the beginning of the implementation. Taken together, these data show that despite some technical and practical barriers, facilitators were satisfied with the implementation of video groups and had a generally positive experience as a facilitator. Responses allude to the fact that although facilitators are happy with virtual groups, they do probably understandably miss in-person interactions with their patients. We were able to identify some practical opportunities to improve the experience of facilitators, which we can address as an institution. Future work includes evaluating patient experience and clinical outcomes, which are underway, as well as qualitative work to dive more deeply into the facilitator experience. We do want to overall understand more concretely how the quality of virtual group care compares to that of care delivered in person. In conclusion, video groups have the system level potential to be used as a means of delivering high quality, accessible care. Thanks so much, and I'm happy to answer any questions that you may have.
Thanks so much, Neesha, for sharing your work on the provider experience. I'll give it a couple minutes since we still have some time for some questions to come in. I've got one right here. What types of groups were facilitated?
That's a great question. At Women's College, there's really a diverse range of groups that run. They range from mental health therapy groups in psychiatry, trauma therapy groups, educational groups around pain management, and our cardiology department also has a robust range of groups to support cardiac rehabilitation after cardiac events.
Is there any tech support during the video group session aside from the facilitator to assure participants' tech solution?
That's also a great question and so relevant to this type of programming. The patients or facilitators were able to contact central kind of IT services at Women's College if they had technical issues during the course of a group. And one of the limitations was that sometimes that process could be slow because there weren't kind of technical support dedicated to each group running. And so that might delay a participant being able to actually participate in a group session.
If you knew then what you know now, what would be a couple of things you would have tried to do differently?
That's a really interesting question. So I personally, as a student, wasn't involved in the original kind of design and implementation of the overall programming. I came on board more on the evaluation side. Based on the feedback that we've received this far, I think kind of one of the things that went really well was we had kind of almost a train the trainer type of system to be able to ramp groups up quickly, which worked really well, although I think people would like more kind of ongoing support in more of the nuances in how to use Zoom most effectively to run groups using things like whiteboards and breakout rooms and things like that. And so I think integrating that kind of training from the get-go would have been helpful.
I think we have time for one more question. Was there any analysis around the type of group, sensitive nature of the discussion, and the success of the sessions, or preference for in-person versus remote format?
At this point, based on the data that I've presented today, we didn't look at the types of groups separately, just because the majority of groups were more therapy oriented. And so we didn't have enough of a sample size to really separate those things out. We're hoping to look at that in more detail as we get more of the patient side of things. And the second part of that was around the success of sessions or preference for in-person versus remote format. And that's a really interesting one that is starting to become more relevant as conversations around things like hybrid groups or in-person groups become a little bit more realistic given the current climate. And those kinds of questions are part of what we're asking patients who are participating in video groups. And I think if we dive a little bit more closely into maybe some qualitative work with providers and facilitators, getting that information from them is definitely part of future opportunities.
Perfect. Thank you. Thank you, Neesha and Christine, once again. I now would like to invite all attendees to head over to the networking lounge for some lively discussion and virtual connections. Your other option is to join the patient partner meetup from the agenda tab. See you there.